who has not been on one of these meetings before that would like to introduce themselves? Okay, I'm not seeing any new names in our list, so I'm going to say no. So the other item I wanted to bring up is that our next scheduled meeting is on September 2nd, which is Labor Day. So we will not be meeting that day. I will go ahead and send a cancellation for the 2nd. And then the meeting after that, I believe, is September 16th. And so hopefully by then I'm a little behind with a couple things or minutes for the meetings. And also I was going to work on turning our survey list into some question format. So the plan for the 16th is to have that ready and then go through that and see what else we need to discuss before we can submit the survey. So today we have the remainder of the hour with our speaker. I'm going to try to say it again, Václav. Is that right? Yeah, yay, Václav, who is going to be sharing with us the process of transforming the UK Biobank data into the OMOP Common Model. And we're very happy you can join us. We've been very interested in learning how other groups have been dealing with survey data and OMOP so that we can kind of understand what things work well and what kinds of best practices, tools, and priorities we can eventually share with the community after we've completed our landscape analysis, which includes having the speakers and then also the survey I was just talking about. So we kind of see what's been done. We don't want to reinvent the wheel, but we also want to make it easier for those who wish to do this in the future. All right, so thank you for presenting today, and I will turn it over to you.
Thank you, Nicole, and thank you for inviting me with this talk into this work group, because it sounds definitely as a very this topic is definitely very interesting and it's worth of dedicated working group for sure. My name is Václav. I'm from Institute of Health Informatics at the University College London. I'm a research associate there, and quite recently, well, maybe it's not quite recently anymore, but I've been a part of the project which aimed to transform the UK Biobank data resource into the OMOP Common Data Model. Now yeah, here it is. The main objective, the main goal, the main aim, the reason why we were doing all of this was because we wanted to contribute into the federative research on COVID-19. There was a rapid collaboration call, so we applied, and we've been one of the data providers contributing with our OMOP data source into this federative research. We've been transforming UK Biobank. UK Biobank is a population-level longitudinal research study. It contains about 500,000 patients within the age range between 40 to 69 years. It contains the data from all UK, from multiple resources. There are like 2 or 3 resources from England, another data resource from Scotland, another data resource from Wales. Northern Ireland is not included in UK Biobank, I believe. I'm not 100% sure. These participants into this study been recruited between 2006 to 2010. And then there was a repeated assessment between 2012 to 13. When it comes to UK Biobank data itself, maybe the 500,000 patients is not a massive cohort of patients, but on the other hand, the multimodality of the data is quite massive. So UK Biobank contains so-called baseline phenotypic data, which is mostly survey or questionnaire data, containing information about diet and alcohol, about physical and biomarker measurements, data about cognitive functions, about mental health, education, employment, and many others. There is about 8,000 different data fields within this baseline data, and most of it is using proprietary dictionaries. Then UK Biobank contains electronic health records from primary care as well as hospital care, as UK Biobank gathers the data from all the UK, also the recording practices between different GPs, between different hospitals from different corners of UK differs basically. So we've been facing a lot of different terminologies, a lot of different vocabularies used in there. Then there is a cancer registry as part of the UK Biobank, National Death Registry. We also obtain COVID-19 measurements data, and there is also one part of the UK Biobank data is about binary data like imaging data, genotypic data, and others. As the OMOP Common Data Model is not, um, let's say, suitable for the binary data, for imaging data yet, we've been focusing on the highlighted ones. That means the baseline EHR records, cancer registry, death registry, and COVID-19 measurements. I suppose that in this group, introducing the OMOP Common Data Model is quite pointless. So I'll just say that we use the OMOP CDM in version 5.3. And as I said, the goal was to be one of those diverse data sources. So we would be able to execute the one very same study code from the same study protocol, which was designed for those different participants in that COVID-19 study. We knew from the beginning that we are standing in front of a couple of challenges, and many others appeared during the study. Firstly, the baseline data we had, it was in a wide format, which basically means a massive table of 8 to 9,000 columns. Then a lot of data, and especially the baseline data, the questionnaire data, contained proprietary codings, nothing standardized. Then we've been facing a different coding system and different coding practices for the electronic health records. And finally, and obviously, when we are talking about proprietary codings, we've been facing the situations where there were no existing mappings between those proprietary or less known vocabularies into those, let's say, standardized like SNOMED and similar ones. This is like a rough schema how this transformation process worked. Basically, all the development was created and all the ETL scripts being developed by the SME, the Hive, a company from Utrecht, which is focusing on working with OMOP and these transformations. And we performed a white rabbit scan over all our data tables of UK Biobank. Then we created a synthetic data in the corresponding structure. Why? Because due to some policies and data governance and so on, we've been unable to share the we've been unable to share the raw data with the developers. So they had to develop the ETL on a synthetic data using Odyssey tools or other tools like their in-house built Delphin framework, which helped them to create these ETL scripts. They provide us, like the UCL, these ETL scripts. We executed them on the raw UK Biobank. We validated the results. We gave the Hive the report. They refine the scripts according to that report, and we've been iterating that way till the moment we've been fully satisfied, and we said, okay, now we are happy with the final version of the OMOP. As I said, UK Biobank contains a lot of different parts, a lot of different kind of data. And if I understand it well, you're focusing on survey data, on questionnaire data, and so on. So since this point forward, I would like to mention, or I would like to provide you our experience with processing this baseline data only and not electronic health records. As I said before, or partially said before, the baseline data contains lot of different pieces of information, like self-reported illnesses, self-reported cancer illnesses, or self-reported non-cancer illnesses, self-reported medications, self-reported procedures, details about demographics and lifestyle. But there were also not just self-reported things, but also measurements and some biomarkers like blood, saliva, and urine biomarkers, and also anthropometric measurements like hearing tests, eyesight tests, and many others. All of these were recording using a bespoke coding system, but not just the one system. It's a whole hierarchy of coding system developed by the UK Biobank. I just present here a little example. Let's take into consideration field 20002, which contains patient-reported non-cancer diseases. But within this field, there can be another 474 unique codes corresponding to different non-cancer disease. And again, it's a proprietary, it's a bespoke coding system developed by the UK Biobank. And there is over 8,000 individual data fields. From this, we excluded any genomics, imaging data, or other binary kind of a data. As I said before, the OMOP common data model is not suitable for this kind of data yet, like accelerometer and so on. And then we start to processing it somehow. So firstly, we performed the White Rabbit scan, and we created a data profile of this baseline data. And we had these almost 9,000 data fields, and we had to prioritize it somehow. So from this, we prioritized 519 data fields, and we did it based on different things. Firstly, we created an OMOP UKB working group, which helped us, and based on engaging of this community of this working group, we prioritized certain fields. Then we used expert reviews for clinicians to identify the key data of high interest, which would be related somehow to COVID-19 research. So also the domain experts or clinicians being involved. And finally, we prioritize these fields based on triaging the fields. So we generated some descriptive statistics, and we sorted, order it according to frequency of the most frequently used values or combination of values and so on. And the most commonly used fields we included in those 500 as well. Once this had been done, we classified the prioritized field as numeric or /continuous and discrete ones. And further, we divided the discrete values as Boolean values, just true, false, or the categorical values, which usually being some string taken from some lookup table or from some preset list of values from some UK Biobank coding subcoding system, or how to say it. And also there were others like units and dates and so on. So
Oh,
we,
Val's Club.
yeah,
I just had a quick question. So
yeah, sure,
obviously
sure, please.
very intense work. How many people were involved in this process overall? Like you talked about having, the clinical experts and getting the data clean to this point that you could figure out, frequencies and
Mhm.
prioritization. I was just curious, like in a, like, yeah, how many people it took to do this?
I'd really, really, really wish to give you an exact answer, but I'm afraid I don't know exactly. There was like a 5 people on a side of the Hive, that company, a software company who developed the ETL scripts. From our university, it was me as a coordinator, Spiros Denaxas as a data or the project designer, and few other people who've been involved or in touch with these domain experts and so on. But how many domain experts were involved, or how many people in the end joined this UK Biobank working group? To be fair, I don't know. And if I should say some number, it would be just the pure guess. So I don't dare to say it.
Yeah, but that was
So,
helpful, like the how you like broke it down, the different groups that were participating. Yeah, because it does not look like a small endeavor. Um, how long did it take? Like from the time you got the okay to move forward this to when you
about two
delivered?
years.
3 years?
About 2 years.
Okay, yeah,
About
that
two years.
sounds.
But, the development itself, once we had all the metadata we needed and everything, it was actually quite smooth. And deploying
Oh,
that
nice.
and everything, it was smooth as well. But really, a long time took the coordination of those working groups and this prioritization and so on. And honestly, I haven't been involved in this directly. I joined just the few meetings there, so I haven't been involved in this prioritizing per
Hmm.
se, and I work more with electronic health records. So there were a lot of like working streams going in one time in parallel, but most of this work was simply well, not theoretically. Obviously, the prioritizing these things is not just the theory, but it wasn't the actual development of the ETL scripts. And once the development started, it was a matter of couple of months.
Okay, all right. So a lot of it was leading up to it, and then once everything was in place, it went pretty smoothly.
Yeah,
Is
yeah,
that
yeah.
okay? Cool. And then I
Then,
had,
mhm.
oh, go ahead.
Yeah, 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 please, please, please.
Oh, and then there was just a question from the chat. So is any of the work or code reusable for other projects or cohorts? So I guess the first question would be, is it publicly available like on GitHub or something? And then, would it be, can you reuse it or repurpose it?
Yeah, I think you can, because the code is publicly available on
Okay,
GitHub. Um, Later on in this presentation, there will be maybe not link, but just a screenshot of the publication where all those links are available, and I can put it later on into the chat as well. So all the codes used for these transformations are available on GitHub publicly.
great.
Um, the thing is that a lot of work is really very, very specific
Hmm.
to UK Biobank. So you cannot simply take it and use it for something else. But definitely, fragments of it could be useful, or maybe even some of the bespoke coding systems, depends on how your data would look like. But especially with the survey data, basically every single data source looks so differently that Hard to say
Yeah.
whether you find it useful or not. But for sure, all the codes are publicly available.
Okay, terrific. No, thank you. And yeah, I understand what you're saying because you're working with a bespoke vocabulary to begin with. But hopefully, from my perspective, I think so, getting a view of what what your Boolean questions were, what categories you had, things like that, I think could possibly still be helpful. But
Yeah,
that's good to
yeah,
know.
yeah.
And thank you, Tamara, for the question. And then we'll let you get back to your slides. Yeah.
So we did this classification into numeric, Boolean, and discrete fields, and we approached when we had a numeric field, then we mapped the meaning of the field onto the concept. But because the field was numeric, there had to be also some units related with that number. So we had to map the units as well. When it comes to the Boolean fields, we did the concept mapping only where the outcome was or the value was true. So we basically ignore the false values. And finally, for the discrete fields, we had to map the concept, obviously, but also the value mapping, because as I said before, most of the discrete values were basically values, string values from predefined set of values. So we had to map this as well. On the right side, in this table, you can see that when it comes to the source terminology, apart from dates, which are basically just dates, everything were encoded using the UK Biobank proprietary vocabulary. And for the continuous type, discrete type, and units, we had to create a bespoke type of mapping to translate it into the SNOMED CT or possibly the unit coding system of the OMOP CDM. When it comes to dates and demographic details, we've been able to map this directly onto the attributes of the OMOP common data model. I have another slide about this in a bit. This is an example how it looks like with a specific data. So, for example, column 30,000, which stands for a white blood cell count, which was one dedicated column in a massive baseline table. We had to firstly map the white blood cell count onto the SNOMED, and then we have to map that the final number is stands for count or stands for grams or stands for something else. In this case, it was a count in a unit mapping. As I said, when it comes to date, it was mapped directly to the attribute of OMOP. This is an example down here. By the way, I'm saying down here, do you see my cursor on the shared screen or not?
Oh, do I see your what?
My cursor, like my mouse,
Oh,
the
you
little
know what?
arrow.
No, I'm not seeing your cursor, but I am
You're
able
not
to
seeing
follow
that.
along.
Sorry, maybe there is a laser pointer. Do you see
Oh,
it
there
now?
we go. Yeah, I can see that.
Okay, brilliant. Sorry, I'm still saying down here, and now I realize that maybe you don't see it. So when it comes to the Boolean values, has your doctor ever diagnosed you with diabetes? Yes and no. If no, we simply ignore that line. If yes, then we map this onto the diabetes diagnosis from SNOMED CT. And
Okay, so
finally, there is the.
oh, oh,
Mhm.
just a quick question. So is the reason you don't map the nose just because OMOP doesn't hold null values? So you're only mapping if it's a yes. Is that why? Yeah.
Yeah. Because we map it on a specific diagnosis, specific concept.
Hmm.
So actually, I don't know how to solve the situation where we would like to say, okay, there is a concept of diabetes type 1 or type 2, doesn't matter, with like negation.
Yeah,
I
I
don't
don't
know
think you
how to do
can.
that.
I think that's, I was
Mhm.
just kind of confirming it because I remember somebody saying on a call, one of the community calls, that yeah, the OMOP doesn't contain null. It's like if you have diabetes, it's listed, but there's not a check. Nope, you don't have this disease. It's just
Yeah,
so that makes sense.
exactly, exactly. And when it comes to the categorical type of data, for example, alcohol intake frequency, which has a couple of values, including prefer not to say and so on. So we had to create a concept mapping for alcohol intake, and also the value mapping, daily or almost daily and so on, which caused another issue because uh, OMOP or the vocabularies supported by OMOP contains really a lot of values, but sometimes still we face the situation where, for example, I'm just saying now, prefer not to say was unmetable, or you know what I mean. I'm not saying that there is no prefer not to say value. Maybe that there is, but sometimes it happened that within this list of values, there was a value for which we struggled to map, and others were fine.
And it's just because
Mhm.
the categories are different, right? Like somebody might have
Yeah,
daily or whatever, and someone else might have 5 days a week or 6 days a week. So your people do those categories very uniquely sometimes across surveys or
exactly.
even with whatever's in the OMAP. So that was a challenge.
Exactly.
Yeah.
One of many, not the crucial one. We
Mm-hmm.
always found like a solution, but yeah, it was one of the challenges.
Yeah.
Um, when it comes to the syntactic mapping and actual processing of the data, um, as I said before, the baseline table was really massive. So first of all, we had to transform it from this wide format where we had one row per patient into long format, one row per patient per data field. So it was incredibly long table, but at least machine processable table. So it was easier. And then when it comes to the patient identifiers, data field values, units, and those dates, we mapped it onto the corresponding fields of the OMOP. For demographic details, sex, ethnicity, or details like date of death, we've been able to map it onto the attributes of OMOP. For others, like those clinical event records, we had to map it onto condition occurrence, measurement, and other domains of the OMOP. We were also using for not sure whether I can say simplicity in here, but for sure it helped us to create a stem table. It was like an auxiliary table in the middle, and we took a lot of data from the source tables, put it into the stem, process the stem table, create some mappings, assign domains to the data records, and then we split it back into the common data model. It was we've been doing two projects with OMOP. The first one we did the mapping right straight away, and in here we use the stem table. For actual details, I'm not sure I'll be able to answer your questions because I haven't been a developer, so
So do you know though, were you able to basically use the vocabularies and other things that are already in OMOP, successfully, or did you have to create any biobank specific vocabularies because you just
yeah,
couldn't map it
I have
specifically?
I have actually two slides on this
Okay.
in a bit because yes, we had to create a lot of bespoke vocabularies. For electronic health records, it was fine. It was for hospital data. It was mainly ICD-10. For procedures, it was
Mm-hmm.
OPCS4. For death data, ICD-10, ICD-9. For primary care data, sometimes one part of the primary care data for or GP data was encoded in SNOMED directly. So we've been able to just take it and use it. That was fine. But on the other hand, other part of this primary care data was encoded in CTV3 and Odyssey vocabularies or OMOP vocabularies, Athena vocabularies, provided just read codes and not the CTV3, which is basically like a next version of the
Hmm.
read codes. So for that, we haven't created a mapping from scratch
Okay.
because we've been able to find a mapping between the CTV3 and SNOMED on the NHS website. So we use this mapping how it's being defined by NHS. But for others, like let's say the self reported non-cancer illnesses, we had to open Usagi and we had to create our own mapping based on the similarities of terms, comparing the weights of two similar terms manually. And we've been doing a lot of this work manually because the the situation here is even for semantic mapping, it was even a little bit more complicated than just creating our own mapping. First of all, we annotated our data by OMOP concept ID using UK Biobank vocabulary from Athena. It exists there. So all those data fields 20,002 and so on, it's there. It's in Athena. But there is no information about mapping from non-standard to standard vocabulary because or standard concept because only thing what this UK Biobank Athena vocabulary do is it carries the information about data field hierarchy structure, about categories, about value encoding systems. It was valuable data, but it tells us nothing about how to map it into standard concept from the perspective of OMO.
Hmm.
So this is something we had to do manually and created such a mapping in Usagi. We have it in this figure in here on the left blue side. This is our source baseline data. We have this data field 20,002, which stands for non-cancer illness self-reported diseases. And within that, from some UK Biobank coding number 6, there was a value 1065, which stands for hypertension. So this was self-reported hypertension in two different codes. In this data field with this value. So we map it onto the UK Biobank vocabulary, which is in Athena already. So we've been able to map this data field onto some OMOP concept ID, and we've been able to map this value for hypertension onto the OMOP concept ID as well. But both of it is non-standard. So then we had to apply the bespoke custom-made mapping, which we created, and we've been able to say, okay, this OMOP concept ID, non-standard, maps to a standard concept ID, which is this SNOMED code for history of clinical findings in subject, and the hypertension is mapped for into the SNOMED CT code for hypertensive disorder. So this is like a double jump we did mapping this data. And where we were unable to simply do the mapping, we carried it into the OMOP anyway. So all semantically unmapped fields were transformed anyway. Just we put them into the observation domain. Concept ID was 0, but as a value, there was the original field ID and original values from the baseline. So in theory, with the knowledge of the original structure, you've been able to track all the records in the OMOP as well. But obviously, for some standardized study code, this would stay hidden as the concept ID is 0. Validation of all our efforts was performed in multiple steps. The developers wrote manually wrote some test cases and automated tests, and they tested it on synthetic data. Then we perform analysis using Achilles tool and data quality dashboard, or from Eden developed CDM inspection tool. And finally, we also created or performed series of comparison of series of metrics between the raw data and how this looks after the conversion. All of this validation was performed mainly on electronic health records or the UK Biobank as a one piece. So we did not distinguish between the baseline data, other data. We simply took it as a whole. When it comes to results, you can see here that we met about a half of ethnic statuses, slightly below 80% of self-reported non-cancer illnesses, almost 60% of self-reported cancer illnesses, about 1/3 of self-reported medications, and about half of all the self-reported procedures. These numbers does not look like a massive coverage, but on the other hand, if you have a look onto the number of events we met, we covered a lot. So the worst coverage is probably for self-reported cancer illnesses. It's not only, but partially it's given by the fact that these data fields weren't so important for the COVID-19 research. But for other events, even if we met just the half of the original codes, in the end, we met 90% of possible events within this category of self-reported procedures.
Yeah, it's helpful to see both parts of
Yeah,
that. Yeah.
yeah. Definitely, because we find out that we, if we would like to, this basically, our estimation is that this basically takes 1/3 of time
Mm-hmm.
to achieve such a kind of a result, and it would be an at least twice more time dedicated to this mapping process to reach the better coverage, which actually was not necessary in this case.
Mm-hmm.
And for the study purposes, we said, okay, this is okay, and we be able to participate in the federative research. In the end, the list of challenges expanded from what we expected at the beginning. So yeah, if I should mention the highlights of the challenges, it was definitely a significant amount of preprocessing and consolidation across multiple fields. We had to create 8 custom mapping tables, plus we used the existing vocabularies from Athena. We had to approach to each type of data differently because it was simply different. There was we faced sometimes quite a peculiar challenge, like we faced an insufficient number of OMOP measurement attributes. So in the measurement table, there was not enough attributes for us to record everything as we would like to. Because, for example, for hemoglobin concentration, we also had related other fields, not just the date, like the device ID, how the hemoglobin concentration has been measured. So this had to be in UK Biobank one thing, and we had to split it into the observation, into the measurement, and into the device record or into the device table of OMOP as well. So those were other challenges. Uh, we basically discussed this before. We've been struggling sometimes to capture the negations or missing data, like patient did not answer or refused to answer the question. Simply, we did not have the answer, so how to store it? So, and another issue, well, in the end, it wasn't a big challenge. We simply did not store this data in the OMO. We've been also fighting, or it was a challenge, with some historical medical events because, by definition, I don't remember the exact details, but by the definition of observation period in OMOP, we've been unable to capture some data because when we had a historical medical events, it did not comply with the definition of observation period in OMOP. So that was another data losses in the end, or data losses, or we simply replace some historical event date with some placeholder like 1st January 1970, for example. In the end, we've been able to put it together. We've been able to publish it in this paper, and more importantly, we've been able to participate in the Eden adverse event of special interest studies. Specifically, we participated in 3 4 subject incidence rate, vaccine diagnosis, vaccine incident characterizations, and all 3 studies were published in the end. And as you ask about the number of people in the team, obviously a lot of people contributed in here, and so I'm acknowledging just some of them in names, but in the end, it was a lot of people participating in all of this, and that's probably all from from my presentation. I'm obviously happy to discuss any further questions if you have any.
Perfect. Thank you so much, Vaslav. It was really nice to see some of the nitty gritty. I think sometimes when things get shared or published, you don't see all the effort on the back end, and so it's really nice the pieces of it you walk through because that's what we're all facing. Several of the people who are members of this group are, also work with cohorts and have similar cohort type survey data, and it's interesting to see that process and also the challenges because hopefully part of the work of the survey group will to be improve some of those things like the things that are lacking in the measurement field or not being able to record historical data because we have very at least I can speak for Connect, we have very similar questions like if your doctor has ever diagnosed you with X, when were you diagnosed with X? We try to get some of that information, but yeah, it's not part of the time they're enrolled in the study. It's from before. So that was really, really helpful. I have Julia, do you just want to go ahead and ask your question?
Yes, hello. Really interesting
Hi.
presentation. I just wanted to ask, considering the amount of bespoke mapping that you had to do and kind of the different mappings that you had to use for each of the different types of data, if you found it to be beneficial to bring in an organization like the Hive to assist UK Biobank, or looking back, if you think it would have been possible to do entirely in-house.
Hmm. I believe that it really strongly depends on what who are the members of the team working on that. Because for, if I'll take it from our perspective at UCL, we had a lot of people there who've been very helpful and who've been great in doing all these mappings and reviewing it and so on. But when it comes to the development itself, um, in the end, from the perspective of Hive, they dedicated not a big a team of developers, but still team of developers. It wasn't developed by one person only. And at the side of UCL, as it was basically me and only me who would be able to do the development, it would be really a very big chunk of work just for me to doing it by my own. On the other hand, if we would have more software developers in our team at UCL, then it would probably be possible to do it just in-house. But it's really depends on the expertise of the group or team members.
Great, thank you.
Sure.
Are there any other questions from the group? I'm just looking at my notes to see if I have other questions. Okay, so yeah, I think you answered most of mine as we went along. Oh, go ahead, Tom.
Yeah, just trying to wrap my head around this because that was a great presentation, and like that does seem like an immense amount of work.
Thank you.
So that, if I understood correctly, that was just the baseline that you were working on. Is
No. We've been doing everything. I just put the baseline into this presentation, but we've been doing electronic health records as well, this death and cancer registries as well, plus COVID-19 data. And all of those other different elements of UK Biobank required another strategies, another approaches, another mappings. So, for example, cancer register had to be for cancer registry mapping, we had to develop another bespoke mapping. On the other hand, hospital care electronic health records were quite straightforward. Really depends. But apart from imaging, and apart from genomics and other omics kind of data, we transform all UK Biobank.
Okay, yeah, I apologize. Yeah, I recall now you did mention that in the beginning, and that's just reinforcing the amount of work that seems like.
It's in some way it was.
Okay, yeah, well, that definitely addresses my question because I was thinking about the other data on there. I think you did address this, yeah, because we kind of looked at this in one of our cohorts, the PLCO cohort of trying to map to OMOP, and yeah, I think we ran into a lot of the problems you were describing, where particularly like the survey things like where we're asking about things like reproductive variables like number of births, age at first pregnancy, and these things just didn't seem to exist in as standard vocabularies in OMOP. So that, I guess, yeah, I'm like really just kind of trying to wrap my head around like within this working group, like where do we go with something like that? Like how do we try to move forward? So
our previous experience, sorry, please.
No, please go ahead. Yeah, because I like, yeah, if you have any thoughts on that, or
I just wanted to say that in our previous study, we converting into the OMOP a database with link electronic health records. There was no survey data, but the transformation wasn't always the straightforward either. But once we had all the mapping tables, sometimes we simply had to map from the source vocabulary into some middle step, from middle step to another vocabulary, and from another vocabulary we finally found a mapping into the standard vocabulary. So we had like multiple jobs. But once we had all these mapping tables, it was quite straightforward. But especially here with the this baseline, UK Biobank baseline data, we realized how difficult it could be when we simply don't have all those mappings. And once we had it, once everything was prioritized, and once we had a lot of CSV files, then it was quite straightforward automatic process. But most of the time has been spent on creating on those mapping tables.
Okay.
So knowing what you know now, having been through this process, is there anything you would have done differently if you were to do it over again?
Me personally, I would do slightly differently the validation because I've been responsible on the comparing of some metrics between the raw UK Biobank and the OMOP version, and sometimes my approach wasn't the most effective one. Now I probably would do it differently. I would very likely build some automatic or at least follow automatic pipeline for that. When it comes to the transformation itself, I'm afraid that this question isn't for me. It would be more for the developers. According to my experience, when we did this first project and then the UK Biobank, a lot of change. The developers use this Delphin pipeline or Delphin framework to put different aspects of the ETL together. So they had a much nicer solution, and it wasn't. Previously, we had only one purpose, one of dedicated scripts for all of this, and this time with the UK Biobank, we had like a more robust solution, which would be easier to modify. Because another thing which I did not mention, because for the purpose of the presentation, it's not so important, but when we started to work with the UK Biobank, the data looked differently. And how we've been working and how we've been investigating the data and profiling it and so on, we received the update for UK Biobank. And some of the data tables suddenly look differently. And a lot of new data, a lot of new electronic health records were newly added, newly linked to the original data set. So half of our work had to be thrown away and started again. And this is something where I believe that developers did a fantastic job, and they really created this ETL, not just scripts anymore, but mostly like a platform, quite elastic or quite flexible to adapt these changes, because it happened to us twice during the development that we suddenly received new data or a different data, and we had to react on that. But whether they would do it differently, something hard to say. I don't know.
Yeah, I hear that, and like you said, you know it from your perspective. One question that maybe might have been related to something you were thinking about, Tom, is lots of times for the cohort survey data that we're collecting, we recollect that data. So for example, we have a baseline survey that they take for Connect. 2 or 3 years after that baseline, we ask similar questions. So basically trying to gather any personal or family history of disease that has been diagnosed since the first one. Is is sort of a repeated measure anything you have to deal with or will have to deal with in terms of survey? And obviously electronic medical records is all kind of repeated measure. But in terms of survey, will that be anything that UK Biobank has to deal with?
Not actually. Well, a little bit, yes, because the survey data from the participants been collected at the beginning of this study between those like 4 years or how long. And then there was some reassessment. And I think that there was one more iterations couple of years after. And so possibly it could happen that the participant would answer differently the same question. I don't remember such a scenario that we would be facing, but in theory, it would be possible. My guess is that we would use the latest or most updated version of the answer to the question. Whether we stored like a history of answers, well, it's also a bit complicated because, for example, if the question would be yes or no, then we stored just the positive answers and not the negative. And I'm not aware of the fact that someone would say, yes, I've been diagnosed with diabetes, and 5 years later, no, I haven't been diagnosed with diabetes. I don't remember such a situation. And when it comes to measurements, then there is obviously a date, so it's easier. Yeah, so I don't have a direct answer to your question. Not sure.
Yeah, but it's good to hear your thoughts. No, that's helpful because you've been through this and we're all just sort of poised about thinking about how we're going to do it or try to make, best practices. Excuse me, I have a frog this morning, how to develop best practices and things for the community. So it's really helpful to get your perspective having been through this process. And so we are at time. There are a few other comments you might want to peruse in the comment section, but thank you so much for sharing this experience with us today. It was really helpful to see that process. And of course, you're welcome to join anytime if you want to see how we continue moving forward with our process. So thanks again, Vaslav. Really appreciate you being here.
Thank you very much for inviting me. Thank you very much for your attention. Also for a very, very interesting question. I'll put you a link to our paper into the chat, not because I would have to show off with this paper, but because there are links to GitHub, and there are links to the ETL documentation about all of this, which you may find useful.
Terrific. Well, thanks again so much. And I hope you and everyone else on the call has a great week.
Thank you.
Have a great
week. Bye, everybody.